or any confusion? There's no problem. I will just briefly write here primary immune mechanism. They may be antibody, yes, mediated reactions to antigen, of course, right? These can be divided into two. In situ immune complexes, yes, in situ immune complexes, or there may be, yes please, or there may be, yes, in situ immune complex formation. In situ immune complex formation can be further divided into two. Yes, intrinsic antigen or planted antigen, because if antigen get planted first, right, then antibody may follow. So it is still in situ. Is that right? And this intrinsic antigen, classical example I've given, type 4 collagen antigen and magalin. Any question up to this? And planted antigen, okay, we can talk about that also. Planted antigen may be exogenous antigen or may be, yes please, they may be endogenous antigens or they may be exogenous antigen. Endogenous antigens like your own DNA stuck over there. Exogenous antigens may be microbial or they may be, yes please, maybe drugs or they may be toxins or they may be unknown. Is that right? No problem up to this. Then we said not only there is in situ immune complex formation, even circulating immune complex can come here. Circulating immune complex deposition. Now look, in this case there was immune complex formation. Here there is immune complex deposition, because here formation of the immune complexes within the glomeruli. Here formation of immune complexes was in the circulation, but eventually they get deposited there. Right? Again, examples of this. What could be the example of this? They may be also endogenous. Antigen may be endogenous or they may be exogenous. Right? This will be what type of reaction? Type 3 hypersensitivity reaction. And this is classically what type? Type 2 hypersensitivity reaction. All this piece of information really clear or there is some problem? There's no problem? No. Okay. Then there can be another type of injury. That is also by the antibody, but now antibodies are directed against the cells. Right? This was antibody which was directed against certain antigens. Now we are going to talk about what? Antibodies found by the immune system against suppose mesangial cells or against visceral epithelial cells, right? So what do we call it? That cytotoxic antibodies. What are these antibodies? Because these antibodies are different than those. These antibodies react with the cells. So they are cyto, yes please, toxic antibodies. So immune system may produce antibodies which may attack the glomeruli, and these antibodies may be reactive against certain antigens which are either present within the glomeruli or planted into glomeruli, or immune complexes come, or antibodies directly react with specific type of cell within the glomerulus. You know the resident cell in glomeruli. Which are the resident cell of glomeruli? Mesangial cells, endothelial cells of capillaries, epithelial cells, podocytes. These are resident cells. So against the resident cell, if antibodies go and damage those cells, glomeruli will be healthy or they will be injured? They will be injured, right? So we call them cytotoxic antibodies. For example, they may damage mesangial cells. And of course, when cytotoxic antibodies will damage the mesangial cells become, they undergo mesangial lysis, and eventually they start over proliferating. This is the primary mechanism of injury. You know what will be the secondary mechanism of injury? As someone irritates you again and again, what will happen to you? You will become abusive. You will start saying the things which normally you don't say. Is that right? Same is true about mesangial cell. When antibodies are again and again irritating the mesangial cell, they become very angry, irritated, disturbed, and they start producing inflammatory molecules. Normally, mesangial cells are not producing those molecules. But when mesangial cells are irritated, they start producing oxygen-derived radicals. They start producing proteolytic enzymes. Mesangial cells start producing nitric oxide, endothelin, cytokines. Of course, that all these things will injure the glomerulus. You get it or not? Right? So immune system, these are two mechanisms I've told you how immune system can damage the initial mechanism of damaging the glomerular components. Any question up to this? That's clear. Then there can be cell-mediated injury in which antibodies are not involved. Cell-mediated injury. Let me tell you one classical example of this. Because in many glomerulonephritis, antibody-mediated and cell-mediated injury both are present. But there is one classical example of glomerulopathy in which, okay, I will give you the clinical picture. I will see you can recognize or not. Usually a child comes with nephrotic syndrome. A child comes to you with nephrotic syndrome. If you do biopsy, under the light microscope, you don't find any change in glomerulus. The cellularity of glomerulus is normal. Cellularity means under the microscope, when you look at the glomerular cells, they are not hypercellular area. They are normal amount of mesangial cells, endothelial cells, and epithelial cells. Even glomerular basement membrane is not thickened, normal looking under light microscope, right? Under electron microscope, you find that some epithelial cells are these are the epithelial cells. Under electron microscopy, in these patients, you find what is this? These food processes are effaced, they disappear. Food processes are swollen and then they disappear. You get it? And when this healthy cell, epithelial cell, convert into this cell, it cannot keep a normal relationship with GBM, and GBM becomes leaky. Is that right? Am I clear? Again, listen. A child of 4 years is brought to you. Child has generalized edema with heavy proteinuria and hypoproteinemia. You put the diagnosis of nephrotic syndrome. If you do biopsy, usually we don't do biopsy because intelligent doctor assumes what is there and he start treatment. But if you do biopsy, under the biopsy tissue, under the glomeruli which you bring out of his kidneys, you find that there are no antigen antibody deposits, no glomerular basement membrane thickening. But under electron microscope, you find epithelial cells have abnormal foot processes, and these epithelial cells may detach from there and proteinuria is occurring. Now, underlying cause, underlying immunological mechanisms, you know what they've discovered is that probably some T lymphocytes are activated. Some T lymphocytes are activated because we don't find any antibody. So it is not antibody mediated injury, it is cell mediated. But even you don't find any T cell there. But they found that in baby's body, some T cells are inappropriately activated. Those T lymphocytes are producing cytokines, and those cytokines are coming to glomeruli and reacting with their negative charges and neutralizing them. Again, listen. What's going on into that baby? We are moving backward. Clinically, patient comes with nephrotic syndrome, right? Morphologically, we find there were not much changes in glomeruli, right? Because we don't find much changes in glomeruli, you know what is the name of that glomerulonephritis? Minimal change glomerulopathy. That is called minimal change glomerulopathy. What is the underlying mechanism? Underlying mechanism is some T cells are activated and they are producing some cytokines, and those cytokines are reacting with negative charges of glomerular basement membrane and neutralizing the charges. So secondary mechanism of injury is neutralization of negative charges and proteinuria start. Still you really know the cause? No. We know the mechanism. We have to go back. You may take the history of the child. You may come to know that very recently he has upper respiratory tract infections, or he got some immunization. So upper respiratory tract infection or immunization which occurred 2-3 weeks back, that activated his immune system. That was the real trigger. An immune system, unfortunately, in the baby went out of order and activated some group of T cell which produce such cytokines which could react with the negative charges of GBM and neutralize them. And when negative charges were lost, heavy proteinuria started, right, without any big changes in glomeruli, right, and patient come with nephrotic. Now this is one example we have taken from where we start. Triggering was some viral infection or some fluctuation in immune system, right, that activate T cell mediated injury. How? That lymphocytes produce cytokines. Cytokines neutralize the charges. Under the microscope, what type of morphological changes? Minimal change glomerulonephritis, and clinically nephrotic. But another class fellow of that baby also come with nephrotic syndrome. Another class fellow of that baby comes with nephrotic syndrome. Or adult friend from the same family, maybe now 20-year-old young male from the same family come with nephrotic syndrome. Now, clinical picture of the baby and the adult is same. But when you do morphological study, in the baby you find there was minimal change, but in adult when you look at the glomeruli, all the glomerular basement membranes are very thick. So what we say? He is suffering with membranous glomerulonephritis. Again, for him also, we have to explain from where the antigens came. What are the antibodies? Is that clear now? Because the tragedy is that students never understand the relationship in these things and they think every glomerulonephritis is a full disease. But actually one type of glomerulonephritis can convert into another type of glomerulonephritis. For example, with moderate injury, you have membranous glomerulonephritis. If injury becomes more severe, membranous may convert into membranoproliferative. And clinically membranous was coming as nephrotic and membranoproliferative may come as nephrotic. You are understanding? According to the dynamics going on in the glomeruli, clinical presentation of the patient will change. Let's come back now. So you understand cell-mediated injury, the one example I have given you, right, in which there is no antigen antibody involved. Is that right? Just cells produce cytokines which neutralize the charges, and those neutralized charges lead to heavy proteinuria. Then there is another mechanism of injury. It's very, very unfortunate, which I'm going to tell you. In this case, you may not find any antigen at all. And something is happening very strange in patient body. In this example, in the patient body, there is inappropriate activation of alternative pathway of complement. I'm going to talk about a type of glomerulonephritis in which there is inappropriate activation of alternative pathway. You know, alternative complement pathway, let me tell you just briefly what it is. Suppose this is any cell. When alternative complement pathway has to be activated, first there will be, what is the first component? C3b. This is the first component. C3b activate another protein which is called BB. C3 and BB together they are called C3 convertase. What is this called? Together C3 convertase. They convert more C3 into active form C3b. And now all of three are called C5 convertase. And they convert, yes, C5b into active form B, C5a will be released, and then C6, 7, 8, and 9. C5b to 9. They are very powerful group of proteins which destroy the membranes. So they are called membrane attack complex. Is that right? Now very briefly I have discussed it. This is the alternative complement pathway. Do you think that of course our blood has all these components all the time. Do you think these complement factors present in the blood should be normally inappropriate? Do you think normally they should be activated easily? No, because if they are normally activated unduly, they will damage our tissue. So there are certain check and balances, right? For example, C3BB, it has a special type of protein which try to stabilize them. It has a positive influence on this complex. But there is another counterbalance, right? And this try to inhibit this mechanism. This is the balance between these two proteins which will determine that there will be activation of complement, alternate complement pathways there or not. Is that right? Doctors found that some patient came with nephritic syndrome, and when they studied their glomeruli, in the glomeruli they found lot of activated product of alternate pathway, right? But doctors never found why they are activated there, how they are activated there. They never found any special antigen. Then one doctor did funny thing. He took from such patient his serum and put into another person. The second person also developed the disease. Then he said, okay, there must be something in the circulating serum which is producing the problem, circulating plasma. He took some plasma material and inject to other person. Other person also started inappropriate, undue activation of alternative complement pathway. Then he said, there must be something in the blood. He hypothetically called that thing that there is some nephrogenic factor. He said there is something nephrogenic factor in the patient blood which can be transferred other. But they never knew from where that is coming. Very recently they discovered what is that. You know what is that? Anyone knows? $100 prize? Anyone interested in $100 prize? My heart is now having tachycardia. Maybe someone knows. No one knows. They have recently discovered that their immune system is making antibody, and this antibody is reacting with this protein and making it more functioning and making it more functioning. Normally antibody bind with the protein and make the protein dysfunctional. Here autoantibodies are formed against this protein and stabilize into more functional form. So antibody with this protein, both of them over stabilize this complex so that normal system cannot inhibit. Now it is beeping in the presence of this thing. Is that right? That antibodies are formed in these patients against this protein is called properdine factor. Have you heard of properdine factor? And this protein is called factor H and I. So there is antibodies against the properdine factor, and properdine factor is overstabilized, and overstabilized properdine factor overstabilizes C3 convertases of the alternate pathway. So alternate pathway complements are overstimulated within the glomeruli and keep on damaging membrane attack complex and keep on producing other toxic reactive component of complement and damage the glomeruli. That is why when they took the blood of the patient or plasma of the patient and put into another person, this antibody went to the second person also. And in the second person, it also reacted with this properdine protein and enhanced the function of the properdine protein, properdine B exactly. And in second person also, there was undue activation of alternate pathway. So you see, this is another mechanism. What should I write in this blank place? There is another immune-mediated mechanism in which glomerulonephritis can be produced. Is that right? So what should we write here? Undue activation of alternative complement pathway. What is this? Activation of alternate complement pathway. Complement pathway. Is that right? So this completes our discussion only about what are the different primary immune mediated mechanisms which can trigger and initiate the injury to glomeruli. Right? Just to sum up, that immunological mechanisms in glomerulonephritis may be antibodies against the antigens, or antibodies against the cells. Is that right? If antibodies are against the antigens, antigens may be intrinsic to the kidney, or they may be planted to the kidney, or antigen antibody complexes are deposited in the kidney. Is that right? Or if there are antibodies directed against the cells, they may be anti-epithelial cells, they may be anti-mesangial cells, they may be anti-endothelial cells. When they will damage these cells, injured cells will produce a product which damage the glomerulus. Then there's cell-mediated injury, where antibodies are not involved at all, and there are some activated lymphocytes which produce the product or cytokines which damage the glomeruli and neutralize their charges. And then we took the last example in which immune system make antibodies, and those antibodies overstabilize the propertine factors which lead to inappropriate overactivation of alternative complement pathway. Right? After the break, we will discuss about that once immune mechanisms are there, how they activate secondary mechanisms of injury. And then we'll talk about that once these two things you have understood, what are the different morphological types of glomerulonephritis. And you have already studied that. We'll link everything together. Let's have a break.